Laparoscopic procedures have recently led to a renewed interest in anti-reflux surgery, increasing both the number of procedures being performed and the number of practitioners. The relation between the short esophagus and anti-reflux surgery have been a topic of keen interest in the open literature of the past 40 years, but seldom discussed in the recent laparoscopic literature. This may imply that many laparoscopic patients with short esophagi are unrecognized and potentially treated improperly. Intrinsic shortening of the esophagus most commonly occurs in patients with chronic, severe GERD that involves repeated cycles of inflammation and healing with subsequent fibrosis. Other entities associated with esophageal shortening include type 3 or 4 hiatal hernia, Barrett's esophagus, Crohn's disease, and other conditions, all of which are associated with profound inflammation in the distal esophagus and subsequent significant cephalad migration, cephalad displacement of the anatomic GA junction. But most esophagi that are short based on preoperative examinations are actually of normal length. For example, the positive predicted value of the preoperative barium meal to diagnose esophageal shortening is only 50%. In general, preoperative examinations serve only to increase the clinician's index of suspicion. Actual diagnosis of a short esophagus can be made only in the operating theater. Thus, short esophagus is intraoperatively detected as less than 2.5 to 3 centimeters of intraabdominal esophageal length after extensive mediastinal mobilization. The incidence of truly shortened esophagus is unknown. In the review of the current literature, the frequency of esophageal shortening ranges widely from the 60% to 0%. The actual incidence of the short esophagus is estimated to be approximately 10% of patients undergoing anti-reflux surgery. Of this group, 7% can be appropriately managed with extensive mediastinal mobilization of the esophagus to achieve the required esophageal length. The remaining 3%, those with true shortened esophagus, require an aggressive surgical approach. It is inappropriate but frequently used technique to place aggressive axial traction on the stomach without proper mobilizing of the mediastinal esophagus. This can result in a deceptive elongation of the proximal stomach, which can be improperly identified as the distal esophagus and wrapped. Apart from misplaced wrap, it's also wrong to perform a fundoplication properly around the distal esophagus, but when the GA junction is retracted below the diaphragm under tension. Such a repair will inevitably be subject to high rates of transdiaphragmatic herniation. Several surgical options for treating the short esophagus have been reported, including Hill's repair, circular myotomy, bilateral truncal vagotomy, intrathoracic fundoplication, esophageal lengthening procedures, different procedures, even esophagectomy with reconstruction. But methods to treat short esophagus, aside from Collis gastroplasty, have inferior long-term results with increased rates of complications. Because the attenuated and tubularized gastric cardia may look similar to the esophagus at the completion of esophageal mobilization, we mobilize the gastric fat pad of the stomach and distal esophagus using ultrasonic shears. This allows clear visualization of the longitudinal fibers of the esophagus, which does not have a serosal lining, as they merged with gastric cardia, which does have a serosal lining. In the first phase of our experience, We routinely mobilized both vagal nerves off of the esophagus, but not any longer. Theoretically, the circumferential, highly selective vagotomy that is naturally a part of the fat pad dissection might help prevent local acid production. However, complete dissection increases risk of vagal nerve injury, resulting in delayed gastric emptying. If the GE junction does not remain below the diaphragmatic hiatus with an adequate segment of intraabdominal esophagus with no traction, additional step is to scope the esophagus for precise location of the GE junction. If a shortened esophagus is identified, a lengthening procedure is performed. We currently use a wedge-type Collis gastroplasty technique. A wide catheter bougie is inserted transorally into the stomach under direct laparoscopic visualization and is guided along the lesser curvature of the stomach. 1 or 2 staple loads fires are taken perpendicularly down to the bougie until the bougie slides out of the stapler enclosure. With gentle traction of the partially stapled gastric wedge, several additional serial firings of the endostapler are placed parallel to bougie, hugging the bougie to complete the creation of the neo-esophageal segment. The neophandic tip is grasped through the retroesophageal window and passed posterior to the esophagus for creation of the fundoplication. It requires an additional 40 minutes of operative time. Collis gastroplasty does not affect postoperative mortality or length of hospital stay. However, the most significant concern with Collis gastroplasty is the risk of leak at the stapler line, which could be expected in the range of 1 to 2% of patients. In comparison, after challenging Nissen procedure alone, the prevalence of postoperative leaks is expected to be around 0.6%. Regarding long-term outcomes, 16% of patients experience radiological recurrence, and only 3% require reoperation due to the symptomatic recurrence. Patients undergoing paraesophageal hernia repair with Collis gastroplasty experience significant improvement in total esophageal acid exposure, along with an increase in LES residual pressure. Nevertheless, one of the few concerns regarding the use of Collis gastroplasty is persistent acid secretion within the neoesophagus. And indeed, 50% of patients have abnormal pH studies, 36% of patients have persistent esophagitis, and 14% of patients complains on heartburn after surgery. However, in the paper published by Svenstrom's group in Archives of Surgery back in 1998, the prevalence of these abnormal findings in the Collis-Nissen group was significantly lower than in the Nissen alone group. Despite all of that, in the paper published by Lukatic and co-workers in Annals of Thoracic Surgery in 2011, 9 out of 10 patients reported satisfaction, and the same number reported good or excellent GERD health-related quality of life scores. Laparoscopic procedures have recently led to renewed interest in antireflux surgery. This will inevitably increase the number of patients having a short esophagus who are referred to surgeons for treatment. The Collis-Nissen procedure has an established, excellent long-term success rate for this complex problem, even though it's non-physiological treatment and requires a long-term follow-up. And the final tip to wrap things up: good Collis is a short Collis. The whole segment of the neoesophagus should stay within the fundoplication. Your feedback is important to us. Please share your thoughts in the comments below. Click the button to explore more content of the EAES Upper GI curriculum series, or visit the EAES website for additional information. Thank you.